So I'd invite Dr. Gaurav Luthra, who's an internationally renowned cataract and refractive surgeon. He's going to be speaking on OOPS and Phakic IOL. So if you could keep it brief, that'd be good. Any questions for Dr. Sushmita can be taken 1:1.
So I think after those very interesting glaucoma ones, I'll try to just quickly go through as we are short on time. So sometimes as you're injecting an ICL, you will be faced with that dilemma of when the ICL is not going through. So as you inject, if you're not careful enough, if your incision size is not adequate, you're trying to do a wound-assisted injection, which are both no-nos for doing an ICL, you will end up with an ICL which can get stuck. See that cartridge tip gets dislodged. So you need an adequate 3 mm or little more incision, and you should not be doing a wound-assisted injection, and then you can get away with a good implant ICL injection. So I think that's one thing which is critical. And then sometimes you're doing a toric ICL and you think you're doing a refractive surgery. You do a great surgery and then you realize that your 3 mm incision is not sealing enough, and it's leaky, and then you're in a situation and you don't want to suture it. So what do? You can just make a supraincisional tunnel and hydrate that, and that once you hydrate that supraincisional, I don't know why it's repeating itself, but it is. So you just make the supraincisional tunnel and then hydrate that small pocket which is above the main incision, and once you do that, your leakage should stop. This works very well in pediatric cataract as well, and it's just few seconds and it works very beautifully. So going on, sometimes you'll have a poor vault and you'll see that the vault is very low. Second eye, we managed to change the sizing and got this right. And then you want to do an ICL exchange. I think we've seen enough videos. I'll just go to one or two which are more relevant. This patient came up for surgery, and we realized that had been waiting since morning. When he came up in the surgery, the pupil was already small. So another oops moment, either you cancel the surgery or you can just use phenocaine. I think everybody is used to using phenocaine. So this patient had a very small pupil. By the time we loaded the ICL, we put phenocaine. We had a nice big size pupil. You can quickly complete the surgery. You don't have to abort surgeries nowadays. Phenocaine works quite well. You can see how fast the pupil actually builds up. Going to a last case which came up suddenly to us. A patient came up with both eyes IPCL or something similar done elsewhere, and said, one eye I can't see well, and it was looking suspiciously, and there was a cataract. We did an OCT, and we found that the IPCL was upside down, and patient had been walking around for almost a month like this. So obviously that requires you to then explant the lens. Ideally should be picked up right in the beginning and should be exchanged immediately, otherwise this is what you will get. So I think, okay, I'll just show this few seconds and then I'll be out. Sometimes you have these uveitic cataracts. One lady, bilateral uveitis 5 years after ICL, and systemic causes were found, and went on to, over COVID times, went on to had bad recurrent attacks, and when one eye went into this kind of an intumescent cataract, we started off with the surgery, wanted to stain the capsule, dislodged under infusion. We did not use visco because we wanted to stain the capsule. Managed to do all that, stained it under the ICL, and the moment we went and touched the lens, we had this thing. So anyway, now we do femto assisted, and I'll stop here because giving a chance to somebody else to present. So femto-assisted Rexis works beautifully well. So if you have a really intumescent cataract under an ICL, I would strongly suggest that you consider doing an Rexis at least with the femtosecond laser.